Welcome. Welcome to the Fujifilm Healthcare webinar organized in occasion of the ISUOG Congress. Thank you very much for joining. This is one of our clinical activities that we are arranging for this Congress. My name is Luca Mastrogirolamo. I'm European Clinical Support Manager for Ultrasound in Fujifilm Healthcare, and I will be your facilitator for this event. Today, we are really pleased to have as a panelist of this webinar, Dr. Marc Althuser from Grenoble, France. Dr. Althuser is a gynecologist and is an ultrasound expert in fetal medicine. He has a very long expertise in ultrasound scanning, and today he will present a lecture with the title Cavum Septum Pellucidum as a sentinel of midline development. You can place your question to Dr. Althuser on the chat of this platform. We will be very happy to submit them to our panelists for a reply. So I'm pleased to introduce Dr. Marc Althuser. Please, thank you very much for joining. The floor is yours. Thank you.
Thank you, Luca. I have also to thanks Fujifilm for giving me the opportunity to talk about Cavum Septum Pellucidum. It's a common anatomical structure, but not always well known. I ask for your indulgence regarding my poor English. ISUOG guidelines for routine mid-trimester fetal ultrasound scan indicate that we should check that the CSP is normal in appearance. The guidelines of most scientific society also recommending checking this midline. This is the case, for example, for French guidelines. The presence and the shape of the CSP must be checked. Furthermore, a drawing of the image to produce is appended to the recommendations. The CSP clearly appears as an obligation. As we know, the picture of BPD-HC cross-section tilted downwards through temporoparietal suture is showing a CPS in front and ambient cistern in back. Other markers, in addition to CPS and ambient cistern, are third ventricle, thalami, and glomus of choroid plexus in lateral ventricles atria. About CSP. CSP is a crucial anterior landmark. There is, it's important to know that include the CSP on the BPD and HC section is imperative at the second trimester. Because all fetuses in which CSP appears unusual or impossible to identify are suspected of carrying an anomaly, as callosal agenesis and dygenesis, holoprosencephaly, septo-optic dysplasia. The fornix can form a CPS-like trap image. We have to know that. The midline echo is continuous between the two columns of the fornix in A, while the CSP interrupts it in B. In A, the section is too low, and we have the two columns of the fornix looks like a CSP, please, sorry. The right section is a little higher, running through the CSP, and the fornix column are behind the CSP in the right section. Ambient cistern is a posterior landmark for optimal anteroposterior inclination of the section. It is a space of extracerebral fluid bounded below by the vermis, above by the splenium and the cerebellar tentorium, in front by the quadrigeminal lamina, and laterally by the surface of occipital lobes. This is this yellow part on the echographic picture. The CSP and ambient from the median transverse axis helps to have an optimal anterior-posterior section. So now CSP ultrasound anatomy. CSP sits between the anterior third of the middle and the middle third of the anterior posterior axis. The cavum interrupts, as we saw, the midline. There is no median interface in the posterior third of the fronto-occipital axis. So the CSP is in the middle of the effective midline. The line passing through the two coronal suture crosses the CSP. So with these markers, we can easily locate the normal position of the septal cyst. In the second trimester, the median width of CSP is about 1/10 of the BPD value. Normal CSP appears rectangular on the BPD HC section. The length is the distance between the genu of corpus callosum and the top of the third ventricle, and the width is the distance between the medial wall of the frontal horn. CSP anatomical report. The CSP have a roof, a floor, and lateral borders. The roof is a corpus callosum. The floor is a third ventricle with its own choroid plexus, and the lateral border, as we saw, medial wall of frontal horn. If we have not corpus callosum, we have not CSP. On this same reference image, we can also see something like a silhouette of a capital M centered by the CSP. This lying hem corresponds to the striatum, which includes the caudate nucleus, putamen, and globus pallidus. These nucleus are distributed like this on the echographic picture. They are also visible on the frontal view, especially the head of caudate nucleus as seen on this section. The anterior complex is a set of elements around the CPS whose checking improves the detection of midline malformations. The anterior complex component in the axial view are the CPS in the middle, laterally the frontal horns, in front the genu of the corpus callosum, and the interhemispheric fissure. All these components constitute the anterior complex. In a sagittal view, we can see interhemispheric fissure, genu corpus callosum, and cavum septum pellucidum. If we know this picture very well, it's easier to have a screening, a routine screening. Cavum septum pellucidum et cavum vergae. Cavum vergae is a posterior extension of cavum septum pellucidum. If we horizontalize the cutting plane, we can see the rectangle of the CSP lengthen backwards. So the anterior edge remains the genu of corpus callosum, and the posterior edge becomes the splenium, as you can see on this picture. Cavum septum pellucidum is separate in front by CPS, the true CPS, and in the back, the cavum vergae. The border between these two parts are mixed by fornix. As you know, the cavum is an ephemeral structure. It's beginning to collapse from the third trimester, and that from back to the front. It's why it often becomes difficult to spot in late pregnancy. So it is important to identify it at the second trimester. At this stage, if there is a message to remember, it is avoid the fornix traps. These pictures are very similar, but the meaning is not the same. Falling into this trap may have unpleasant consequences for everyone, the fetus, his parents, and the doctor. When the CPS is missing or looks unusual, it's a strong warning for a midline defect. Screening consists of checking the normality of predefined items. This checking is done by comparison with a normal reference, so it's necessary to know perfectly the ultrasound anatomy and to keep in mind the criteria of normality. On the left, and in our mind, the reference image. On the right, the image to compare. At 21 weeks, a normal CSP cannot be obtained, and the third ventricle and the lateral ventricles seem enlarged. So we need a sagittal view. Indeed, there is no CSP and no corpus callosum. But to be sure that we are in a strictly sagittal view, when CSP and corpus callosum are absent, we can use these three curved echogenic lines. These lines are, for the first one, the choroid plexus of the third ventricle, on the top of the third ventricle. The second one is the quadrigeminal lamina, covering the sylvius aqueduct, and naturally the third is vermis. So it's very useful when we have not CPS and corpus callosum in sagittal view. In this case, the lateral ventricle is enlarged and the CPS is too big. A sagittal view is required. We then understand what's going on. It is not the CSP, but an interhemispheric cyst whose presence have blocked the decussation of callosal fibers. The coronal view shows the wall of this cyst. In this quite fat patient at 24 weeks, the CSP is not visible too. Instead, there is a brain parenchyma, a bridge connecting the two frontal lobes. Holoprosencephaly may be suspected. The frontal view confirms this by showing a single ventricle. In this other case, at 22 weeks, CSP is also missing. It was expecting at the intersection between the midline and the line between the two coronal structures. A sagittal view confirms the absence of CSP, and the Doppler shows an abnormal course of anterior cerebral artery passing horizontally above the base of skull, and upwards in front of the brain, because there is no path between the two frontal lobes. In coronal view, communication between the two lateral ventricles and the thalamus seems fused too. A more forward section shows clearly the bridge between the two frontal lobes. In this case, here the non-conformity is the fact of the two frontal horns communicate clearly. The frontal section confirms the communication between the horns, but the corpus callosum is present. The difference between the difference with a reference image is discrete, as you can see, so we have to be watchful. In this case, septal agenesis is obvious. It may or may not be part of septo-optic dysplasia. We are at 25 weeks again. Here we cannot validate that CSP is normal. An eccentric image is in its place. The frontal view illuminates the situation. CSP is present, but a mass pushes it on the side and pushes frontal horn upwards. A parasagittal view shows the mass below the ventricle. Its contents looks like brain parenchyma. The Doppler confirms this hypothesis by highlighting at least two internal arteries coming from the anterior cerebral artery. It was a brain tumor in tuberous sclerosis of Bourneville. Later in pregnancy at 33 weeks, here the area of the anterior complex does not appear quite usual, and additionally, we have a minor ventriculomegaly. These two movies show that the CSP is present, but there are additional elements both sides of CPS. I'll let you show. These two additional hyperechonic elements are calcification, called candelabra picture. There are also calcification at the opposite side, as you can see here. This calcification of the wall of thalamic arteries. These arteries coming from the middle cerebral artery have a vertical path. In addition, we see a band in the lateral ventricle, which indicates ventriculitis. We are here in a situation of cytomegalovirus infection. Finally, we are now at the beginning of the third trimester. Too many fluid images in the anterior complex area. It's very hard to understand these images. The combination of these two views suggests a segmental dilatation of frontal horns, but this pathology doesn't exist. The parasagittal view shows that these are voluminous subependymal pseudocysts. Here, the prognosis is good. It is considered as a variation of normal. Do not confuse canetal cyst or subependymal pseudocyst with and true subependymal cyst. In this case, it may be the consequence of hemorrhagia, infection, or metabolic disease. When the cyst is above the frontal horn, a periventricular locomalacia must be evoked. The prognostic here is worrying. To conclude, 2 points only. First, CSP should be clearly recognizable on each second trimester BPD-HG scan. 2, there is a clinical benefit to systematically validate that the CSP has a normal shape and that its close surrounding appears usual. Thank you for your attention.